Hello, my name is Alex Mendes. I'm a nurse practitioner fellow at the University of Miami. And I'm presenting this poster, which is a literature review, which was the foundation for a quality improvement project that I'm doing for my fellowship here at the University of Miami, Sylvester Comprehensive Cancer Center. Let me share my screen. So the title of the poster is Patient Safety and Timeliness in Cardio-Oncology Referrals. So first of all, what is the HFA ICOS? The European Society of Cardiology, Heart Failure Association, and the International Cardio-Oncology Society, ICOS, created a baseline cardiovascular risk assessment tool. The ICOS created 7 charts to use for hematology oncology services for patients scheduled to receive cardiotoxic cancer therapies. So the hypothesis initially was that disseminating knowledge about this tool can increase the utilization of this risk stratification and increase referrals to cardiology or cardio-oncology, since anthracyclines and improve survival, but not without additional cancer therapeutic related cardiac dysfunction. So this abbreviation will come out a lot, CTRCD. So it's cancer therapeutic related cardiac dysfunction. The basic definition is that left ventricular ejection fraction decline greater than 10% from the baseline, or below 50, or more commonly, recently 53. So the problem is that currently there is no widely accepted standardized model to guide risk stratification for CTRCD. The problem is that the survivors will keep increasing. Actually, by the year 2040, updated information, it will be actually about 26 million. So the American Society of Clinical Oncology made guidelines to recommend continuous surveillance for adults on cancer treatment with a true history and a physical exam associated with the serial echocardiograms, which is close surveillance. I'm not going to read all the PowerPoint because I want to guide you more. So the idea is that there's a review of the current recommendations nationally and internationally. And basically here is saying that the European is actually more ideal. They say that this baseline should occur prior to the anthracycline therapy, at 3 months, at 6, 9 months during therapy, and then 12 to 18 months after initiation of therapy. In 2017, the American Society of Clinical Oncology posted the current guidelines, which have been reviewed in 2021, but it was not the guideline. So the current guideline is still the one from 2017. In this guideline, they address pre, during, and post surveillance guidance. But they highlight there that patients that are considered to be high risk could have 6 to 12 months. So they don't include all the 3, 6, 9 months into therapy, but they do recommend for the post that you do a 6 to 12 months post therapy. There was also another article and systematic review in 2019, which is anthracycline chemotherapy, induced cardiotoxicity in breast cancer. And there is a very important statement here that say that once the left ventricular ejection fraction reduction, or clinical CTRCD, of 10% or below 53 is noted, or symptoms are felt, then the damage to the myocardium is irreversible, and the prognosis becomes very poor. So that's why I did a literature review looking at different tools. The ICOS has a strength that is ideal for the identification of high-risk absolutes. It's a very complete risk factors that can be factored and give a complete picture of the patient. But one of its weakness is that every patient that got anthracycline, it's actually considered high risk. So basically, anybody screened would be high risk, and that is not the ASCO recommendation. The ASCO recommendation, which we'll review shortly, is more specific and will not consider everyone. Here's an important algorithm showing that if the patient don't meet the criteria of 10% drop in the ejection fraction or gets below 53, then this patient can be identified to have subclinical CTRCD by doing the echo. So only by looking at the echo, this patient is asymptomatic. The EF is not clinical for CTRCD yet. But if you do the echo, including global longitudinal strain, which is actually measuring the damage to the myocardium. So strain is actually damage. So it's like a coil. If you have a coil and you stretch it, it loses its potential. So it's like a bone too. When you have bone density, if your bone gets like thinner, it gets weaker. So same thing with the heart. So that's to stress the importance of the GLS to be associated with the ejection fraction from monitoring echo, which will be during therapy, or surveillance echo post-therapy. So now, finally, the recommendation from ASCO in opposition to the ICOS recommend that a patient that is high risk for CTRCD get an echo 6 to 12 months after therapy. So what's the conclusion? The ICOS versus the ASCO. The ICOS is more comprehensive, but the ASCO is more specific, and it is our national guideline. So in a way, they can complement each other, but the conclusion is that you had to rest your foundation on our clinical guideline and reflect that into daily practice. The recommendation is recommendation 1.1, which shows which patient is at high risk. So basically, if you have anthracycline that is equal, a dose that is equal or greater to 250 milligrams per meter square, or epirubicin, then this patient is high risk. Separately, if this patient alone got radiation with more than 30 gray to where the heart is in the treatment field, that is also high risk. Now, the next category is a patient that received less than 250 and less than 30. So if you receive less than 250 and less than 30 gray radiation to the chest, then you are high risk too. Now, the tricky one is that if you received a low dose but no radiation, then you need 2 risk factors to be high risk. You need to have extensive history of smoking, hypertension, diabetes, dyslipidemia, obesity. So that can be take more work on to doing this in a busy daily practice. So that is a barrier. But besides that, if the patient receives less than 250 and he's 60 years old or older, then he is high risk. He has a compromised cardiac function with the ejection fraction already between 50 and 55. has a history of myocardial infarction, valvular dysfunction. So this patient is high risk. And lastly, the patient that received a low dose anthracycline, which was followed by trastuzumab. So that defines two different forms of CTRCD, which you have type 1 and type 2. Type 1 is anthracycline, which, as we're stressing, is reversible, and trastuzumab, which HER2 therapy, it is reversible. But when these are given together, like in the setting of breast cancer with a patient that is HER2 positive and estrogen positive too, then this risk, it's already computed to be high risk too. So the conclusion that I like to address and comment on future direction is that we did a baseline on 50 patients from breast and sarcoma. We found that out of this 50, all these patients are high risk according to ICOS. And out of this 50, 45 were high risk according to ASCO. And then we looked to see out of this 45, how many had post-treatment echo to detect this subclinical CTRCD that could lead into heart failure, that could be prevented if identified early. Only 5 had it, so that's 10%. So we identified that for the moment, the most important thing was to identify the high-risk patients and monitor them. And ideally, like with the European guidelines, once the structure is of the day flow in the clinic, it's more established, then the ideal world, this patient should be stratified when the decision to give anthracycline is made. So this avoid the problem in the future that this patient is coming for a follow-up and you don't know, or you don't have the time to identify them to be high risk. So in a nutshell, that's what we're doing. It's kind of like a triage. The direction of the quality improvement project was changed based on this literature review to identify those that are receiving currently anthracycline and are high risk, so we can close and monitor them closely. And the future direction is to maybe incorporate in the treatment plan, as the moment that this patient is established that we receive anthracycline, then the risk stratification should be done, documented, and make sure that it's shared with the oncologist and the advanced practice provider working with him. That's it. Thank you very much. I'll be very happy to get any further questions or collaboration. Here is my contact. You can also find me on LinkedIn. And my email is afm95@miami.edu. Thank you so much for your time and attention. It was a pleasure. Thank you.